Good morning, everybody. I welcome you all to the second plenary today on challenges and opportunities for improving outcomes in diabetic nephropathy. Today, we are pleasure to welcome Dr. Janaka Karaliyadda, a very special guest from UK. Dr. Janaka Karaliyadda is a consultant physician in diabetes and endocrinology and internal medicine at Guy's and St. Thomas Hospital, London. He speaks frequently at national and international meetings, and he has published more than 100 articles, including book chapters. He will be sharing with us his expert opinion on improving outcomes of diabetic nephropathy. May I cordially invite Dr. Janaka Karaliyadda to talk on challenges and opportunities for improving outcomes in diabetic nephropathy. Over to you, Dr. Janaka.
Thank you very much, and good morning from London. I'd like to thank the organizers for giving me the opportunity to talk today at your important conference. And it's my pleasure to speak about kidney disease and diabetes. I hope you can see my screen. So what I will start is by giving a brief update on the changing natural history of diabetic kidney disease. I'll focus on the importance of multifactorial intervention, focusing on glucose control, but also blood pressure control, lipid-lowering therapy, and new treatment options, specifically the SGLT2 inhibitors, which are now recommended in many national and international guidelines as standard of care for people with diabetic kidney disease. So whenever I do a talk about the kidney and diabetes, I start with this slide. And this is an important slide because it tells you the elegant features of a physician who had hundreds of patients queuing up to see him. And this is a picture of an English physician more than 600 years ago from the Canterbury Tales. And he has three essential components to be this stylish physician where everyone wants to see him. He has a beautiful horse, he has an elegant gown, but most importantly, in my opinion, he has this flask made out of leather. It's called an accoutrement or a fashion accessory. And more than 600 years ago, it was recognized that to be a stylish, elegant, excellent physician, you needed to have this accoutrement or accessory of a urine flask made out of leather, highlighting the importance of urine analysis, telling us what is happening inside the body and giving us an idea of disease processes, not only of the kidney, but of many other diseases in the body. The urine gives you a window to understand many pathological processes and diseases in the body. The importance of urine analysis. And this is really important in the context of diabetic kidney disease. This shows the natural history of diabetic kidney disease. Patients, often after 5 or more years of diabetes, can start getting albuminuria, the earliest bedside marker that we can identify, a simple test of the urine, which tells us that the albumin-creatinine ratio, as it elevates, is the early marker of kidney disease. As albuminuria increases, GFR starts to decline progressively, and there is this phase of significant proteinuria and then rapid decline in GFR, generally occurring 5 to 10 years or more after the onset of diabetes. So this albuminuria is a key marker for us to identify people at high risk, not only of kidney disease, but also of cardiovascular disease, because albuminuria is telling us that the blood vessels are leaking, there's endothelial dysfunction and vascular permeability. So an important marker of kidney and cardiovascular disease risk. This grid for the classification of chronic kidney disease is very familiar to you. And we now grade chronic kidney disease depending on GFR, different stages of GFR, and different degrees of albuminuria. These are the units we use in the UK, but the units in many other countries are similar and shown on the right in terms of milligrams per gram. As you can see, is as the GFR declines and as albuminuria increases, you have this heat map of increasing risk of kidney disease and also of cardiovascular disease. So the presence of albuminuria and kidney disease measured by kidney function is very, very important in terms of classifying the stage of chronic kidney disease from stage 1 down to stage 5. It's very important to appreciate, however, that in a patient with a GFR above 60, so greater than 60, you have to have the presence of markers of kidney damage, be it albuminuria, be it hematuria, be it abnormalities on a renal scan, for example. You have to have this evidence of kidney damage markers to classify someone with CKD. A patient who has a GFR below 60, you need 2 results below 60 to confirm the diagnosis of CKD, but you do not need to have evidence of kidney damage markers. What we know in reality, 600 years after that elegant physician from the Canterbury Tales showed us the importance of urine analysis, is sadly, we still do not diagnose chronic kidney disease early. This is data from the US, and we have very similar data from Europe, which suggests that the large number of people with early stages of chronic kidney disease are underdiagnosed. And this is mainly because even though we may be better at doing serum creatinine and getting an estimated eGFR, we are not very good at measuring urine and assessing albuminuria. And this is important because if you can identify someone early with chronic kidney disease, you can intervene and prevent the progression of kidney disease, but also reduce their cardiovascular disease. So we need to do better in terms of diagnosis and measuring urine, ACR, and albuminuria. And this is because once you have early kidney disease, this is a slide from a study done in Taiwan, in Asian people, a huge study. And what we can see here of several 100,000 people is that the presence of early diabetic kidney disease at early stages is associated with a significant loss of life of between 15 to 17 years. This is major loss of life, and this is related to the very high risk of cardiovascular disease and early mortality that patients with chronic kidney disease suffer from. And in London, where I work, I run a large diabetes, renal, and cardiovascular service. We have a huge problem of young people developing diabetes in their 30s and 40s. This is type 2 diabetes. And in younger people, you also have this huge loss of life because they're so prone to getting vascular complications affecting the kidney, the eyes, and the cardiovascular system. So the presence of early kidney disease shortens your life expectancy by up to 16 years. So again, this is so important to identify, but also to prevent. And for many people with chronic kidney disease, sadly, they will die prematurely of cardiovascular disease before ending up on dialysis. So for people with type 2 diabetes, as you can see here, the risk of progression to end-stage renal disease or dialysis, or the risk of death, which is predominantly cardiovascular death, is so high. Many patients with chronic kidney disease, even at early stages, will die early, sadly, of cardiovascular disease. So the presence of chronic kidney disease at any stage identifies to you a patient at very high risk of cardiovascular disease. This is an important take-home message. The presence of CKD equals a high CVD risk state with a significant loss of life expectancy. For people who do end up on dialysis, I run special clinics for people on dialysis, and these are patients who have a very, very poor prognosis, sadly. Their life expectancy is worse than many, many cancers. The quality of life of people on dialysis is really, really low, and they suffer so many barriers, so much impact on not only their lives, but their families and their carers. And if you look at life expectancy in people on dialysis, you can see here that cancers that affect the breast, the colon, and the prostate actually have a better prognosis than many cancers than people on dialysis. The only cancers that have a worse prognosis is stage 4 lung and pancreatic cancer compared to dialysis, as you can see here. And over 5 to 10 years, sadly, more than half of people on dialysis will die prematurely. So we really need to prevent dialysis and understand the importance of chronic kidney disease in terms of its early identification and optimization of care to prevent cardiovascular disease, but also to prevent people ending up on dialysis, which is really a devastating complication with such high mortality, worse than many, many cancers. So if you have a patient with diabetes and you have chronic kidney disease, there are many challenges. This slide briefly summarizes those. The kidney is an important organ in terms of excretion of many drugs, but also of metabolism of certain drugs. So doses have to be adjusted for many therapies that are renally excreted. It's often underappreciated that insulin is removed by the kidney, and that when kidney function declines, there is a reduced clearance of insulin. So insulin is staying in your body for longer, having a prolonged effect, and there's an increased risk of hypoglycemia. As your eGFR declines into stage 3 and 4 CKD, as the GFR falls below 45 and below 30, you have insulin resistance related to uremia and acidosis. And also, the kidney has an important function making glucose. The only two organs that possess enzyme for gluconeogenesis are the liver and the kidney. And if you have chronic kidney disease and you have reduced renal function and reduced renal mass, there's reduced renal gluconeogenesis, which means all of these factors make the management of diabetes very challenging, but you have to be aware of the risks of hypoglycemia. Low blood sugars are significantly greater in people with chronic kidney disease due to all of these factors, including the reduced glucose synthesis and the prolonged effects of insulin and other therapies. So the risk of hypoglycemia is 3 to 4 times higher. So if you have a patient on insulin or a sulfonylurea, it is vital that they understand the importance of blood glucose monitoring, be aware of the risks of hypoglycemia, and if feasible and it's practical, to consider alternative therapies that have a lower risk of hypoglycemia, such as gliptins or GLP-1 agonists. Focusing very briefly on blood pressure, this slide is from more than 30 years ago, but it gives such an important message. This is GFR loss, mils per minute per year. And this is not estimated GFR, but when we used to measure GFR from radioisotopic methods, so much more accurate. Here you have systolic blood pressure. And what this shows is that getting the blood pressure down saves the kidney significantly. And this is GFR loss mils per minute per year. So aiming to get that high blood pressure down, even towards less ideal values, is better than leaving a patient with untreated hypertension, where they could be losing 10 mils per minute per year of GFR. Lowering the blood pressure close to 130/80 is the target we aim for. How low should we go in a patient with diabetes and advanced kidney disease? What we can say from this study, which is the ACCORD study, which looked at people with type 2 diabetes, the SPRINT study, which you are familiar with, did not have people with diabetes. However, in the ACCORD study, they measured the impact of lowering blood pressure below 120 millimeters of mercury systolic. And it found that actually, if you push the blood pressure too low, especially in people who've had diabetes for 10 to 15 years, and they have chronic kidney disease, you can actually cause kidney harm and can cause increased risk of adverse events. So we recommend a blood pressure between 120 to 130 systolic for kidney protection. Pushing the blood pressure too low can be dangerous, especially in the elderly patients and especially in people who have cardiovascular disease in the context of coronary perfusion, which may be impaired with diastolic pressures that also are low. If you look at the risk of kidney disease, we have treatments that we have been using for 20 years. Losartan and irbesartan were the last two drugs licensed for kidney protection in type 2 diabetes. And these drugs reduce the risk of end-stage renal disease and dialysis by around 20%. But there is a residual risk. There's a remnant risk where patients still progress to end-stage kidney disease despite inhibition of the renin-angiotensin system. And this progression and residual risk requires us to have new treatments to target the kidney in people with diabetes. So for the last 20 years, we've not had any specific treatments for diabetic kidney disease. But like many things in life, this is Westminster Bridge that I cross to go to work and the bus that I take often. And you can see that you wait, and then suddenly you have a solution. And the new treatment that we can offer people are SGLT2 inhibitors that work on the kidney. They promote glucose excretion, but importantly, they have glucose-independent benefits for the kidney related to renal protection and cardiac protection. The key studies have been many, but I just summarize a more recent study, which is DAPA-CKD, which studied more than 4,000 people. 68% had type 2 diabetes, but there was also people without diabetes. GFR was 25 to 75 mils per minute inclusion, and all the patients had a raised albuminuria on a RAS inhibitor. So on top of standard of care, which is a RAS inhibitor, an ACE inhibitor, or an angiotensin receptor blocker, the addition of dapagliflozin reduced the risk, the relative risk of progression to kidney disease, GFR decline of 50%, end-stage renal disease, renal or cardiovascular death by 39%, absolute risk reduction of 5.4%, and a really remarkable number needed to treat of 19 to prevent a severe adverse renal event. And remember, this is on top of your ACE inhibitor. Adding a SGLT2 inhibitor provides remarkable kidney protection as well as cardiovascular protection, and also demonstrated reductions in mortality. The benefits were seen in people with and without diabetes, and that's why these drugs are the new treatment option for many people with kidney disease. We mustn't forget the basics, however. Improving glucose, getting the blood pressure down, 120 to 130, lifestyle is so important. Your ACE inhibitor will not work if the patient is on a high salt intake, and many of my patients require a lot of advice on reducing their salt intake. Lipid-lowering therapy, get the patient on a statin, statin of at least 40 milligrams of atorvastatin or equivalent to get their cardiovascular risk down. Smoking cessation and treatment with either ACE inhibitor or angiotensin receptor blocker. You should not combine them. You only use one of these, ACE or an angiotensin receptor blocker, and the new treatment you would add is an SGLT2 inhibitor. So doing the basics, sadly, we still see patients come to our clinics where the basics are not done well. So the ABC is individualize the A1C, get the blood pressure to target, increase the RAS inhibitor if you're using an ACE inhibitor, up-titrate the dose to get the best renal protection. Aim for good cholesterol control because of that high cardiovascular risk. Be aware of precipitating factors that make kidney function worse, non-steroidal anti-inflammatories, recurrent infections. Give advice on salt, and as I will discuss, look for other causes. We spend time talking to patients what to do if they become unwell. And then we also talk about the importance of lifestyle and smoking cessation, which can really make a huge difference to cardiovascular and kidney disease risk. These are the international guidelines for the management of diabetic kidney disease. Lifestyle, we start with the process of lifestyle, nutrition, importance of multifactorial interventions that I've already covered. If you look at glucose-lowering therapy, the advice is metformin, which we know we have to stop if the GFR is below 30, and we reduce the dose to 500 milligrams twice a day if the GFR is between 30 to 45. We now recommend adding an SGLT2 inhibitor and continuing the treatment even if the GFR drops, because these drugs provide glucose-independent benefits for the heart and the kidney. If additional glucose-lowering treatment is required, there are many, many treatments we can consider. GLP-1 receptor agonists are expensive, but they do have the best data for cardiovascular protection, but other therapies can be used, and be aware of the risks of hypoglycemia with insulin and sulfonylurea, which are less expensive, but also have a risk of hypoglycemia. Some practical advice, because SGLT2 inhibitors are very fashionable drugs now, and everyone is using it, from the heart doctors to the kidney doctors to the diabetes doctors, general physicians, and primary care physicians. You need to be cautious in the very elderly, especially if they're very frail. You should not use it in people with type 1 diabetes or diabetes due to pancreatitis or people with a very high alcohol intake. I do not use it in people who have acute severe infection or people who are going on very low carbohydrate or ketogenic diets, because these drugs can rarely be associated with ketoacidosis. In a patient who is losing weight with very high blood glucose levels, who is thin, this is a sign of severe insulin deficiency, and you would not use an SGLT2 inhibitor. This patient requires referral to a diabetologist and assessment for possible need for insulin. Do not use it in people who have a history of diabetic ketoacidosis. In people who are acutely unwell and they come into hospital, or they are in a pre-operative setting where they're nil by mouth and they may require major surgery, you would temporarily stop the drug and restart it once the patient is medically stable. And this is important advice, especially when you have patients with COVID or other acute illnesses. Stop the drug temporarily, but restart it, please, once the patient is better, eating and drinking and able to go home safely. Some teaching points just before I conclude for junior doctors and trainees in the audience. If you have a patient with diabetes, with advanced kidney, eye, or heart problems, remember, a slow and steady approach is needed. This is a marathon, not a sprint. These patients have had diabetes for 10, 15 years. Their body has reached a steady state. We need to improve the blood pressure. We need to improve the glucose. Of course, we have to do that, but please don't drop it rapidly. Dropping the blood pressure rapidly in 4 weeks, or the glucose very rapidly, can actually cause some harm. You need to reduce it slowly and steadily, working with the patient and adjusting treatments. Another key message is that please remember, people with diabetes get other illnesses. Not everything a person with diabetes is related to the diabetes. If a patient has neuropathy, this may be related to diabetes, but be aware of other causes of neuropathy like B12, folate deficiency, malignancy, other causes, alcohol. There are many other causes to consider. Please look for other causes and factors, because identifying that can help manage the patient better, but also may improve the outcome for the individual. So if you have a patient with diabetes, I'm just putting this slide just to remind people to think about non-diabetic kidney disease. In my clinics, we often identify other causes. Look for a rapidly declining GFR. If it's more than 15 mils per minute, this may be due to another reason. Look for the presence of new onset proteinuria or nephrotic range proteinuria, refractory hypertension, the absence of retinopathy. Look for signs and symptoms of other illnesses. If you see a rapid reduction in GFR after initiating an ACE inhibitor, this may be renal artery stenosis. Sudden onset proteinuria without previous microalbuminuria tells us that this is something unusual. We often find maybe hepatitis B, hepatitis C affecting the kidney, myeloma. There are many, many differential diagnoses to consider. Hematuria clearly requires investigation for other causes. And if you have someone who's got a short duration of diabetes with significant kidney disease, think for other causes, look for other causes, because identifying those causes may give you a reversible reason to improve the patient's kidney disease and also improve their life expectancy. Please look for previous renal function data. This is data for young people that we have who ended up on dialysis. And a key take-home message is don't look at the renal function, the serum creatinine at one time point. Please look at previous values. If you know where the patient came from their kidney function, you can have a better idea of predicting the future trajectory. Please look and try and find renal function results from earlier visits, because this can tell you the progression rate of the patient. And we find in our younger type 2 patients, especially, that they can have a rapid decline in GFR, but if you know their trajectory, you may have a better idea of predicting their risk of progression and also improving their care. And this is a patient of ours who sadly had a rapid progression of kidney disease over time and then sadly ended up on dialysis. He now has a transplant, but he went through a long journey. And what this tells you is that often when you look back over time, and when they came to my clinic here, and you look at previous clinics, you can see that generally patients are seen 2 to 3 times a day. There's an economic cost. In the UK, people do not pay for the doctors, but the healthcare system collects money through taxation. So there's always someone who's paying for it, either directly or indirectly. As his kidney disease gets worse, the number of appointments goes up and up and up. He's now almost living in the hospital. His cost of care goes up and up and up. And then he has all these complications affecting his heart. Dialysis costs around 15 to 20,000 pounds a year, very expensive, and also in many parts of the world, very unaffordable to people. And if you look at hospital costs, this is Guy's Hospital. I wish I work here, which is the Shard, which is owned by the government of Qatar, and it's a Shangri-La hotel, but I work in a less elegant building here on the right. And if you look at the view from the Shard, I've never been to the Shangri-La hotel, but this is the view. And this is a bedroom in the Shard, and this is a bedroom at Guy's Hospital. And what is surprising is that actually hospital costs are much greater than 5-star hotel costs, because in a hospital, you're paying for the bed, the staff, the medications, the electricity. And there's economic cost to healthcare systems and to many people who have to pay for this care. And by preventing disease, by acting earlier, we can prevent patient-related outcomes that are devastating to their quality of life, but also economically very devastating for many countries and for many, many people. So early intervention and treatment is the key message to prevent the progression of kidney disease and the devastating consequences of this illness. So to conclude, early identification and diagnosis is so, so important. Please don't forget the picture of that elegant physician looking at urine. Identify the patient early to optimize multifactorial care. Treat with good glucose control is important, improving the HbA1c as close to 7% as possible. Remember to do the basics better. Early diagnosis, starting on a RAS inhibitor, up titrating the dose. There's no point being on a small dose of losartan or irbesartan. You need to increase the dose to get the kidney protection and improve cardiovascular risk. Please look for previous renal function results. We can look at serum creatinine or use the serum creatinine to estimate GFR. Looking at previous results gives you a very good idea of the rate of progression to identify people at high risk who may need more individualized care and more frequent follow-up. SGLT2 inhibitors are now the new treatment we can offer people with diabetes, and these drugs significantly reduce the progression of kidney disease and delay dialysis and also prolong survival. And this is an important new treatment we can offer people, but please remember the basics. Doing the less expensive things is so important, and doing those well and then offering SGLT2 inhibitors is the solution to improve the outcomes for people with diabetes and kidney disease. So thank you very much for your attention and for your kind invitation to speak today.
Thank you, Dr. Karliadda, for that excellent presentation and also for keeping on time. And also for that last slide, I think which will linger with us till the end of the day and also in our practice day to day, because it's always better to prevent than to cure. Thank you.